So I have a really high opinion of Dom's work and in general all the work on ketogenic diet. But as he mentioned, the elephant in the room, here we have it. We have an elephant in the room. The elephant in the room is you're curing someone of whatever, cancer, epilepsy, you name it, traumatic brain injury, only to increase their risk of having a heart attack because you're increasing their cholesterol, because it is a high-fat diet. It's actually a diet that is not endorsed by the American Heart Association because you're allowed to eat all that saturated fat. You eat the saturated fat, which is animal fat or tropical oils, increase your cholesterol, therefore increasing your risk of heart disease, right there out of the American Heart Association, the diet heart hypothesis. And in fact, we're faced with a barrage of advertising and information emphasizing consumption of saturated fat is unhealthy, raise your cholesterol. So what do we want to do? We want to avoid saturated fat. We want to eat food. We want to eat beans and cholesterol, Cheerios to lower our cholesterol. And we want to take statins, of course, lower our cholesterol to reduce our risk of developing heart disease. This became important to me because I'm a neuroscientist, not an expert in cardiovascular disease, at least not in the past. This became important to me, and some of you are aware personally, because 10 years ago I was diagnosed with dyslipidemia. I had extremely high triglycerides, 5 times what are considered normal levels. My HDL, the good cholesterol, was extremely low. LDL was high. I mean, everything was way off without going into too much detail. But the bottom line was I was basically diagnosed with being at very high risk. Here you can see relative risk. I'm over there on the right with my combination, put me at over 15 times likelihood of developing heart disease compared to someone with ideal lipids. And I do recall very well my doctor sitting me down years after I had this persistent. I was going to exercise this out. I was going to follow a low-fat diet. And I kept telling him I could get my cholesterol down. And finally, he actually used this on me. He said, you've done all you can. The exercise hasn't worked. The diet has worked. You must go on Lipitor, as well as other medications to get my triglycerides down. I remember that very well. And I also remember being amenable to the idea that perhaps medication could help my dyslipidemia. But I also thought at the time, well, gee, I've got a PhD in biology. The least I can do is read a little bit about heart disease, read a few papers, and then see, well, if the medication is effective, then fine. I would take the Lipitor. So I read a few papers, which over the last 10 years has become a few thousand papers and dozens of books on the topic. And that's what's led me here to you today. So I want to acknowledge, since there's a vast amount of research that I've read, and this is just a subset of the individuals who I've been very much influenced by in their research. Some writers I've actually been able to work with, and the individuals here that have asterisks are those individuals I have worked with and involved with either publications on the work I'm presenting today or involved in potentially working on projects which will lead to publications. So I really am very indebted to these outstanding researchers. I'll be distilling this down just to the next half hour, which I'll be talking about what I've learned for the past 10 years in cardiovascular disease. Disclosure of a sort. So I've had continuous funding for almost 30 years in my neuroscience research, which I'm not covering. Been funded by these federal organizations at the top. I've also been very well funded by drug companies. So understand, I have no problem with pharma-supported research, even though I will be criticizing it. I've been very well funded, and so I have no personal bias against medication, neither personal nor professional. And so as far as the cardiovascular disease, this began purely as a personal venture for me. And so everything I'll be presenting to you today is unbiased, unfunded, no conflict of interest. My only interest really is to present the science as accurately as possible. So what I want to dispel just very quickly is the diet component of the diet heart hypothesis. So I'm really not going to go into much detail. To me, this is very clear. The evidence is absolutely clear. It's come through in the last 5 years with some really nice reviews and meta-analyses in which the conclusion's right there on the bottom. When you look very closely and separate lifestyle and carbohydrates, and you look specifically at saturated fats, the conclusion is very straightforward. Saturated fat consumption alone, without carbohydrates, does not increase risk for cardiovascular disease, stroke, or type 2 diabetes. So I think that's enough said on that topic. And what Don was talking about as well, improving cardiovascular biomarkers. Very clear that you see an improvement with cutting back specifically on carbohydrates, whether it's a very low-carb diet or ketogenic diet. So here is just a magnificent review by scholars in the field of nutrition, pointing out all the benefits of targeting carbohydrate restriction, especially for individuals with type 2 diabetes. And so when you go over the individuals and you look at the low-fat versus low-carb diet, the low-carb is as good or typically superior to low-fat diet, whether one is looking at weight loss, A1C, fasting glucose, increase in HDL, and a dramatic reduction in triglycerides. So as asides, I was able to reduce my triglycerides by 75%, increase my HDL, and normalize my lipids without medication just by using low-carb diet. So I saw this presented at a conference recently, this particular work, and a clinician pointed out, but what about the LDL? And as Don mentioned, sometimes the LDL will increase. And right here, you see that small LDL? The clinician pointed it out and said, what about the LDL? You're increasing risk for heart disease. And Eric Westman, giving this talk, an outstanding diabetes researcher using low-carb diet, said, I can't believe you're pointing out the LDL. These people are dropping their blood pressure. They're dropping their blood glucose. They're getting off their meds. And you're so worried about the LDL. Don't worry about the LDL. But the clinician came back and said, we have to worry about the LDL. And so this is the state we're in which there's such great concern over LDL cholesterol, because by itself, it is seen as a causal influence on cardiovascular disease. So I'm going to be focusing mostly on cholesterol and specifically on LDL component of the cholesterol, also called the bad cholesterol. So, of course, any med student learns about familial hypercholesterolemia, which there's a mutant gene in which you end up with very high levels of cholesterol. Very well studied first half of the 20th century, in which what you have is very high levels of cholesterol, typically 2 to 3, 4 times normal levels. And the idea is this seeps into the coronary arteries, and then you see cholesterol in the plaque in the coronary arteries. The assumption, therefore, is it's the cholesterol, therefore, that's causing the heart disease. And in fact, you see in young people, you do see an increased incidence of heart disease. An association, therefore, is that the cholesterol in the blood is causing the heart disease. Well, it's very simple then. We have a couple hypotheses. There should be a high rate of premature death in people who have familial hypercholesterolemia. Second, by reducing the cholesterol, if it is the cause of heart disease, we therefore should see a dramatic reduction in the incidence of heart disease, especially coronary death. So I went in with this assumption, looking for the literature on lifespan and familial hypercholesterolemia. And this is the first paper I found. In the Journal of Medicine, published in 1966, one of the largest studies ever published on hypercholesterolemia individuals. Over 1,000 people, huge study, looking at multiple generations. The conclusion was very unequivocal. No evidence that people with hypercholesterolemia have a shorter lifespan, men or women. In fact, they found it very common that you would find people living into their 7th and 8th decades with this so-called disease. There are many, many studies that I could point out, so I have only time just to show a few. I'm not looking at any anomalous finding or flawed study. I'm going to show you just some representative studies of people with familial hypercholesterolemia. So here what we have is, and these are relatively old studies because they're now considered unethical. You can't study someone with this disease without putting them on a statin. But prior to the 90s, you have a lot of studies published on these people without control over their cholesterol. So here's a study of older people diagnosed with familial hypercholesterolemia, extremely high cholesterol. And it is unfortunate that in the older studies, you don't have LDL distinguished sometimes from total cholesterol. But LDL tends to be proportional to total cholesterol. Bottom line is these people have extremely high total cholesterol, so it's at about 325. Your expected, therefore, or the ideal level of cholesterol would be total cholesterol below 200. So these people have extremely high cholesterol, which is considered dangerous. They're 60 to 74 years of age at the beginning of the study. So they're at the prime age when you have the highest rate of heart disease, people dying of heart attacks. They are now followed for 10 years. And you look at their rate of mortality, both coronary mortality and all-cause mortality. The 100% rate here is the average for the Society for people their age. So 100% means that they will be dying at the same rate as the people their age. Greater than 100% means they die at a higher rate. Less than 100 means they live longer. They don't die at the same rate. So you look at these people that have extremely high cholesterol in the prime time in which they're about to have a heart attack, and what you find is a 31% reduced rate of death in people with astronomically high cholesterol, with this disease that's been diagnosed. And this did not escape at all the author's comment. in which they're stating that the relative risk of death, specifically from coronary heart disease, as well as all-cause death, was reduced with increasing age. If cholesterol itself is atherogenic, this makes no sense. And so as you get older, when you are at greater risk for developing a heart attack, if you have that high cholesterol, you should be at greater risk. You should have a higher rate of mortality. So this makes no sense in thinking about cholesterol as inherently atherogenic. Here's another study. There's a reverse causation interpretation of this work sometimes. People say, well, you have low cholesterol, you die because you have cancer or some other disease which is causing you to die. So soon before you die, you have low cholesterol. Well, here I've got a study, 20-year longitudinal study, older people, 70s, 80s, and 90s, which you're looking at rate of death, both coronary death, all-cause mortality. And what you're finding is that in these individuals, when you look over the course of 20 years, you see increased mortality in older people with low cholesterol. And in fact, people have higher cholesterol, you see that they are healthier, they live longer. People with higher cholesterol have less cancer deaths and less death from infection. Overall, you do not see greater mortality in older individuals that have extremely high cholesterol. I love this statement. It's about the most candid statement I've seen in a medical paper. We have been unable to explain our results. It's like everybody told us cholesterol is supposed to kill these people and they're living longer. But actually, in their discussion, you can see they review the literature, which actually shows that their findings are consistent with all the other longitudinal findings, especially of older people at highest risk of developing heart disease. And so they conclude the data cast doubt on the justification for lowering cholesterol in elderly individuals. So I would go over many more papers, but I just don't have the time. So my colleagues and I reviewed every paper published on older individuals, that's people over 60, and LDL levels. We did not find a single paper that showed a higher rate of mortality in older individuals with the highest LDL. And in fact, overall, the title says here, there is lack of association or even reduced mortality in individuals with the highest LDL. And our conclusion, this published in BMJ Open, elderly people with the high LDL, elderly people with high LDL live as long or longer than those with low LDL. So it certainly leads one to question whether LDL itself is inherently atherogenic. Why is it that when people are at the prime age to die of heart disease, those with the highest LDL are showing lower levels or equivalent levels of coronary death or all-cause mortality? So is there evidence then? We talk about older people. What about the evidence of people in mid-age, less than 60 years of age, in relation to cholesterol and coronary heart disease? So here is one of the most famous, most influential studies on cholesterol ever published, the Mr. Fit study, a massive study of over 350,000 men mid-age. And what it found is frightening. And it says right here, there's a relationship between serum cholesterol and death from coronary heart disease. It is continuously graded. That is, you see this increase. Any small increase in cholesterol is associated with an increase in death from heart disease. And in fact, every 1% increase in cholesterol is associated with a 2% increase in death from heart disease. So people have studied this paper, and I look very closely at it. And so I understand this is a relative risk factor. It's not actually showing you the raw data from the study of 350,000 men. So I looked actually at the data. The raw data are provided in the study. And the question is, what's the actual percent of people that actually died in relation to their cholesterol levels? And so that's what I'm now showing in blue, the percent of people that did not die of heart disease in relation to their cholesterol levels. And that's in blue. So just pause for a moment and chew on that. Understand, the same raw data are used to generate the bars in blue as well as those in red. And so essentially, there's no difference across cholesterol levels when you look at percentage of people that did not die of heart disease. So to make this a little easier for you, I put in a line at 99%. So essentially, about 99% of the people in the study did not die of heart disease. At the lowest level, that's slightly above 99, and at the highest level, that's slightly below 99. So how do you go from the blue bars to the red bars? What you do is take this difference, right here, 99.7% did not die of coronary heart disease, so that's 0.3 actually died. All the way at the extreme, the highest level of cholesterol that you see for about 99% of the population. 99% of these people with the highest cholesterol did not die of heart disease. 1.3% did die. So again, how do you get to the red bars from here? What you do is take that 1.3, divide it by 0.3, and you get 4.13. That's how you go from 1 up to 4.13. That's how you can tell people that there is a 400% increase in death from the lowest to the highest level of cholesterol. What they did not tell people is that 400% is actually based on only 1% difference in the actual rate of death from heart disease. So why do they do this? Well, they have a choice. You can report the red data or the blue data. And what happened was, in the 1980s, it was a bit of a crisis time. The cholesterol hypothesis, cholesterol causing heart disease, was failing. And Jeremiah Stamler had been committed to the idea that cholesterol must cause heart disease. So given the choice between the red and the blue data, he chose the red. And that's what was publicized, and that continues to be publicized. We know now that actually the total cholesterol really doesn't correlate very well with heart disease. So in a sense, this is useless, but it is still cited as evidence that any small increase in cholesterol puts you at risk for developing heart disease. So let's now look at, obviously there must be a benefit, because the great push now, obviously, is to reduce your cholesterol. The emphasis now is with statins. So what is the benefit of actually lowering your cholesterol by any means? Well, I don't have time to review the older history of cholesterol-lowering medications and approaches with outcomes. But beginning in the 1960s, for the next 20 years, there are a variety of approaches in which you could lower cholesterol and look at coronary outcomes. And they all failed. Drugs, surgery, diet, you name it, they were all a failure. And you can see that in this introduction to this paper in 1984 in JAMA, which is basically summarizing 20 years of cholesterol reduction history. Many trials of cholesterol lowering have been conducted, but they've been inconclusive. Inconclusive means they have failed. So this trial was going to be different. This trial was a huge investment by NIH to show once and for all that lowering cholesterol would reduce the risk of heart disease. So this is a $140 million study in which you got blood samples from almost 500,000 men, middle-aged men. They picked the men that were in the top 5% of cholesterol, averaging 290 total cholesterol. And those are the men that were included in this study. So therefore, they were at the highest risk of developing heart disease based on their cholesterol levels. You have half of the men put on a cholestyramine, which is a bile sequestering agent, effectively lowers their cholesterol. Half were put on placebo. They're now followed for about 7.5 years, long enough to be able to see if the cholesterol-lowering treatment would have a beneficial effect on coronary outcomes. This study was a watershed event. This study, for the first time, showed that lowering cholesterol actually reduced the rate of death from coronary heart disease. And I've cut this and pasted it directly from the study. The treated group experienced a 24% reduction in coronary heart disease death. So this was the first time that lowering cholesterol actually worked. The downside is that, in fact, all-cause mortality was not reduced. Those individuals on the cholestyramine did not live longer than the placebo group. So how is it possible to reduce death by 24% and yet not overall reduce death? People were not living longer. I will show you the actual raw data from this study. You have the cholestyramine group in red and the placebo group in blue. And below, you're seeing all the different potential outcomes from this study. Look closely and look for that 24% mortality benefit, and you will not see it. These are the actual data from the study. What I'm showing you here is the percent of subjects that did not have an adverse outcome. So an adverse outcome, for example, being death. And so the percent of people that did not die, so that would be survival. Identical data for survival. And so where is the mortality benefit? It's right here. this category right here, coronary heart disease, death. You see that microscopic difference right there? This is a 24% benefit. As hard as it is to believe, this is JAMA, 1984, that is a 24% difference. I'm not kidding you. This is real. The actual data are that the cholestyramine group had 1.6% of them died, and the placebo group, 2% of the individuals died. The actual difference in death was 0.4%. So how do you turn 0.4% into 24%? Well, you take the relative risk measure. So relative risk means you're taking that difference between the two, 0.4%. You divide it by the rate in the drug group, 1.6%. That allows you then to say you have reduced death by 24%. You have taken a minuscule effect, 0.4%, which actually started with 500,000 men, got down to the 5%, and the difference between the group was 8. The two groups was 8 men in terms of death. 24% is now the finding. So, I also want to emphasize, this group published a methods paper in advance in which it said, based on the sample size and our expected outcomes, we consider that there should be a more rigorous standard of statistical test. They published a statement that they would set their standard. For those who understand about p-values, they would set their p-value for significance at 0.01. When the findings came out, and they were so small, they changed that. After this is published, and they have now the data, not only were the findings not significant at the 0.1 level, they were not significant at the 0.5 level, which is the accepted level of significance. They then accepted, they changed, that this would now be a one-tailed test. So they went from accepted two-tailed 0.1 to a one-tailed test, which is in violation of all accepted rules for statistics. So ultimately, there were no statistically significant effects. The largest study ever conducted in lowering cholesterol in people completely failed. It did not find any statistically significant effects. So $150 million was spent, found no effects on mortality, trivial effects on coronary events, and so what the investigators should have done was say, listen, we gave it our best, we tested the hypothesis that cholesterol is actually causing heart disease, and that hypothesis failed. Instead, they declared victory. They said, we can now control heart disease by reducing cholesterol. This is the cover of Time magazine, which is a complete misrepresentation of the study. The study was a drug study, it was not diet. But this emphasized the Diet Heart Association. They said eating bacon, which had nothing to do with this study, raises your cholesterol and causes heart disease. And so what Basil Rifkin said, this is a turning point in cholesterol heart disease research. He said, we can now help people from having heart disease by lowering their cholesterol. Complete misrepresentation of the finding. And he emphasized then, we need drugs that are better than cholestyramine because it's got a lot of bad side effects, GI side effects. So we need less expensive, more palatable drugs. That ushered in then more modern pharmacological approaches. We're now in the era of more specific approaches. And so what we've got, the two primary approaches for the last 25, 30 years are the statins, which inhibit HMG-CoA reductase, or the CETP inhibitors. Now, the CETP inhibitors are far better than the statins because what they do actually is modify liver metabolism to increase HDL and decrease LDL. So you're increasing the good cholesterol, you're lowering the bad cholesterol, which is far superior to the statins. So the CETP inhibitors, the drug companies have spent billions in drug discovery on this particular drug because it's ideal. And so you have about 20 years of tests for the CETP inhibitors. And here, basically, instead of going over the data, I'll just show you the news reports on this, in which they completely failed. The drug reduced LDL, which he said is dangerous, the expert called dangerous, increased the HDL, the good kind. It seemed to do all the right things. There was absolutely no benefit. And this is not just one study. Multiple studies over the past 20 years. Tens of thousands of people have been studied with the CETP inhibitors. These are really very focused, minimal side effects in the later developing drugs. You can dramatically increase HDL, lower the LDL, and it has absolutely no effect on coronary outcomes. You contrast that with the statins. So the statins are very widely prescribed drugs. The statins are the wonder drugs. And so here you see an ad, for example, for Lipitor showing a 36% reduction in risk for heart disease. So it's a far greater contrast to the CETP inhibitors. This work, which I'm showing you, so I don't have time to review the entire literature, but this is one of the most profound findings. This is one of the greatest findings in the statin research area. This 36% is one of the largest effects you'll see in the statin research, and it's what propelled Lipitor to generate about $120 billion in revenue. So we're going to take a closer look at this study. And just emphasize, you look at the summary of the study published in The Lancet, discussion is 36% reduction in fatal coronary heart disease and non-fatal MI. So we look at the data, and it looks remarkably like the 1984 JAMA paper. Here are the actual data from the study, the Lancet study. And so somewhere here is a 36% risk reduction of heart disease. So the asterisks are now, unlike the 84 paper, now you have statistical significance using the 05 level. So where is the 36%? And again, you're looking at the percent of people that did not have an adverse event. And so they're almost all near 100%. So right here is a 36% reduction. When you go from that red group to the blue group, that sliver of a difference, that is the Lipitor effect. That is the effect that generated $120 billion. That's 36% reduction. So how do you get to 36%? The actual difference between the Lipitor, atorvastatin, and the placebo in terms of the incidence of rate of effects, the percent of people that did not die of heart disease, was 98.1% atorvastatin. 97% of those on placebo did not have a fatal heart attack. That difference is 1.1%. All right. So you've got data that can be expressed two different ways. You've got 1.1% and you've got 36% from the same raw data. And so you look at this ad, did anyone notice the asterisk? In the asterisk, you've got both data. There's blue font on a blue background. There it is. So I'm not kidding you about this. There's really a 1% difference, and it was right there in the ad. What the 36% means is that the patients on the placebo, 3% had a heart attack compared to 2% taking Lipitor. The difference is 1%. You know, in my field of neuroscience, where I study antidepressants, people debate as to whether antidepressants really are effective because they're only 10% better than placebo. In cardiovascular disease, you only need to be 1% better than placebo to generate $120 billion. So how do we get to the 36%? Well, it's the same thing that was done in 1984. You take 1.1%, which is the difference between the two groups. In this case, you're taking the difference of placebo to 100% for really no good reason at all. And then you have a 3% difference. So you take 1.1 divided by 3, and now you have transformed a 1% effect into a 36% effect. This, to me, frankly, just to put this in perspective, is a lot like if you've got a financial advisor, and at the end of the year he says you've made 1% on your money, and you complain about that, and he says, well, don't worry, that's 36% better than I did last year. But it's not putting money in your pocket. What really matters is how much better are you doing than the placebo. So the real effect is 1% better than placebo. So understand what that 1% means. That means that your number needed to treat is 100. You need to treat 100 people as a 3-year study. 100 people for 3 years to have one person have one less heart attack and have no improvement whatsoever on mortality. There's absolutely no mortality benefit with statins whatsoever. So I really think in truth in advertising, what people should see is the absolute risk reduction. Can you imagine seeing Lipitor reduces heart attack by 1%? Well, to me, This is actually what they found. It's 1% better than the CETP inhibitors. So, but they're obviously not going to do that. But the 1% that you are getting, you can still say, well, okay, 1% is better than nothing. But with that 1%, you're getting a whole host of adverse effects. This has clearly been suppressed by those who tend to advocate the statins, but these are all published in peer-reviewed medical journals, clearly showing that there is a host of adverse effects of statins. Erectile dysfunction, low testosterone, kidney disease, the muscle atrophy is very well described. Diabetes, type 2 diabetes, very common. We know you could double the rate of type 2 diabetes from statins, doubling of the rate of breast cancer in women who use the statins, as well as increasing cataracts. So this is only a subset of the adverse effects that have been well documented by statins. And so I've only covered this briefly and I've limited time. I go into much more detail in a paper I published with Uffe Ravenskov. This is published in Expert Review of Clinical Pharmacology a couple of years ago. In this, and the title basically says it, we have been deceived. We have been deceived to believe that statins are wonder drugs. The relative risk statistic has been used to inflate minuscule effects for both primary and secondary treatment of heart disease. We reviewed the findings that elevated levels of cholesterol are in fact found to be associated with equal or even greater longevity. We reviewed the deceptive practices using relative risk in multiple studies, which we illustrated there, and we also reviewed how the small benefits of statins are clearly offset by their adverse effects. So the evidence is very strong. This LDL is not causal as far as an influence on coronary heart disease. People have normal lifespan for those who have familial hypercholesterolemia, normal lifespan for elderly individuals with high LDL, and there are weak to non-existent benefits for lowering LDL for the variety of drugs called cholestyramine, the CETP inhibitors, statins, as well as the newest generation of drugs called PCSK9 inhibitors. All have trivial effects, yet they could massively lower LDL levels. So if not cholesterol then, what is it that causes heart disease? So here we have an ancient study, again, people are not on medication lowering their cholesterol. So these are people, again, familial hypercholesterolemia, astronomically high cholesterol, total cholesterol here over 300. And in this study, we're able to see the LDL, the bad cholesterol. You want the LDL to be below 120. These people are more than twice the recommended level. And you have the HDL and the triglycerides. No difference between these two groups. You have one group, these are older adults diagnosed with hypercholesterolemia. The one in red have been diagnosed with coronary heart disease. Those in blue, no evidence of heart disease. No difference in their lipids. So clearly the LDL is not causing the heart disease if there's no association of LDL with heart disease. So what is the difference between the two groups? Clotting factors. What distinguishes the group with heart disease and those without heart disease is the clotting factors in their blood. So those that have a higher incidence of heart disease have higher fibrinogen as well as factor VIII, the primary clotting factors. And that is independent of their cholesterol levels. Here's another kind of fascinating study, more recent one, in which you have people who did not have their cholesterol lowered, familial hypercholesterolemia individuals, but a more modern study looking at genetics. And what's fascinating here again is no difference in total cholesterol or LDL, slight differences in their HDL and triglycerides. But the most important thing is the individuals that had coronary heart disease were those that had a polymorphism of a gene for coagulation, for the prothrombin gene. They are more than 2.5 times likely to develop heart disease compared to those that did not have that polymorphism. Identical lipids, or very similar lipids, identical LDL, but a difference in their clotting gene makes the difference in whether or not they have heart disease or not. So it's not the cholesterol. A subset of individuals with familial hypercholesterolemia have increased clotting activity. So it is the clotting activity, not the cholesterol, that's killing these people, a subset of them young. I'm currently writing a review of all risk factors for coronary heart disease. And when you look at all, perhaps most, if not all risk factors, what they have all in common is increased clotting, either platelet activation or reduced fibrinolysis, that is, reduced capacity to reduce the clotting itself. And so when we look at every factor involved that's known to be associated with heart disease, and it's curious, bacterial infection, independent of cholesterol, triggers clotting in our bodies. Stress and getting old, now advanced age, in the absence of exercise. Older people who don't exercise have more coagulation activity. Smoking, independent of cholesterol, triggers platelet activation. Being obese, high blood sugar, inflammation, hypertension, and the subset of individuals with hypercholesterolemia that have more clotting factors, those are the ones that develop heart disease. It all funnels through platelet activation. So, bringing this now to a close as far as talking about mechanism, how can we actually relate then atherosclerosis to coagulation? And so what you have here, I think, is a very important cross-section of a coronary artery with the beginning of atherosclerosis. You see here a core of lipid filled with cholesterol. And so what you've got here is an intact intima. Here's the lumen where the blood flows. You have an intact intima, and inside, this is where the atherosclerosis develops, inside the wall of the artery. So one theory is, well, the LDL works its way through damage to the intima to find its way inside, burrows in, and then the intima recovers. There's a far easier way for the LDL to get inside the artery, and that's through the vasa vasorum. Vasa vasorum is a microvasculature that feeds the center of the coronary arteries. Coronary arteries are so thick they have to have their own vasculature. And so what you've got are microvessels all around the coronary artery, and they have these little arterioles that go into the center of the artery. These are barely larger than capillaries and very easily blocked. And so what you've got is decades of research showing that the vasa vasorum is easily blocked. It is blocked by a variety of different influences, and so ultimately what you have is hypoxia in the middle of the coronary artery caused by blockage of the vasa vasorum. You go back decades, and you see the link of vasa vasorum hypoxia as the trigger stimulus for atherosclerosis. So the way to think about this is when you've got conditions that block the vasa vasorum, not the larger artery, but blocking these microarterioles. When the vasa vasorum is blocked, then you have hypoxia followed by necrosis. The middle of the artery dies before anything's happening at either end. And so the middle of the artery now has necrosis. You then develop atherosclerosis inside the middle of the artery. You have neovascularization because the vas vasorum then has massive growth to try to recover from the hypoxia that's developed from the blockage of the vas vasorum. So to bring this to a close, what I've got here is a sequence that explains coronary heart disease and shows how it is not LDL that causes it, but it is in fact blockage of the vas vasorum. The hypothesis is that every phase, from the initiation to the progression of coronary heart disease, is based on repeated episodes of hypoxia in the vasa vasorum. And so what you've got here is a vas vasorum, which then has to intrude into the media of the coronary artery because this tissue is dying. So you grow then more capillaries and more tissue. Ultimately then what's happened is because there is necrosis, you have damaged tissue, you need the LDL for repair. So the LDL ends up inside the middle of the artery as a part of the repair process. In addition, we know that bacteria are clearly associated with the development of heart disease. So as this tissue becomes damaged, it is susceptible to intrusion by pathogens. So the LDL works with the white blood cells to actually kill the bacteria. It is a part of our immune system. So we take the entire sequence, combine stress and high blood sugar and coagulation. We start with elevated blood glucose, blood pressure, and platelet aggregation. We then have vasa vasorum obstruction. The hypoxia then follows in the media of the artery wall. The tissue dies. You then have infiltration with pathogens, which is why you find bacteria actually within the plaque. As a result of that, you have inflammation. The white blood cells combine with the LDL explain the inflammation within the artery. The plaque forms, which is the extension of the lipid and the cholesterol and calcium in here. Plaque forms. Now as this thickens with repeated blockage of the vasa vasorum, the lumen narrows. And it may narrow completely so as to cause a heart attack when a clot blocks the lumen, or the plaque ruptures into the lumen, and you have a myocardial infarction. All this explained without having to blame LDL as a causal factor in heart disease. So bring this to a close. In summary, I want to acknowledge, in particular, Uffe Ravenscoff, who for decades has been providing this kind of information. I consider him a bit of a messenger for a large number of people who are basically emphasizing an empirical, objective approach to development of heart disease. And so the first is a cholesterol-centered approach to the etiology and treatment of cardiovascular disease has failed. And this is also presented in a paper from a decade ago by Uffe Ravenscoff, in which he said basically these findings, and this is 10 years ago, are unknown to most doctors and researchers, that the cholesterol hypothesis has failed. Second, coagulation and fibrinolysis factors. This can actually explain cardiovascular disease far better than cholesterol can. The pharmacological reduction of LDL has failed. It has failed to improve cardiovascular outcomes without offsetting adverse effects. The interventions that I'm suggesting should focus on the lifestyle, diet, and pharmacological approaches that target the hypercoagulation and increase fibrinolysis. That is, increase our capacity to reduce clots. And I want to close also by, in a sense, paraphrasing Sir Isaac Newton, who said he could see farther because he stood on the shoulders of giants. And I feel very much that I have stood on the shoulders of giants in this area. I've been able to take the information from a large group of individuals who've been publishing this work, which I now can share with you today. And so there's a book in which I have a chapter in with Uffe Ravenscoff. The title says it all. Fat and cholesterol don't cause heart attacks, and statins are not the solution. So there are over 20 articles, 20 chapters in this book by MDs, PhDs, including numerous cardiologists, presenting the real science underlying the cause and the benefits of targeting coagulation rather than targeting LDL reduction. I thank you for your attention.
Thanks, David.